From Redfield Medical Direction, I'm Lynn Nguyen, Associate Medical Director, and this is your February 2025 EMS Protocol Review. We are finally nearing the end of flu season, so I'm sure that everyone has run into a handful of kids with fevers. For some reason, parents are always freaked out over how high the fever can get. What parents fail to understand is that fever itself is not a disease. It's a symptom of an underlying condition, like an infection. In a healthy child, fever is a sign of a good immune system, a natural response to infection. A higher fever does not necessarily mean a more serious illness. What's more relevant is the patient's overall appearance and other symptoms rather than the fever itself, which is why it is important that you obtain a full history and do a thorough physical exam. If the kid looks overall well and there's no red flag signs, you don't necessarily have to transport after giving a dose of acetaminophen. But if there is a fever with neck stiffness, headache, or an unexplained rash, your differential should include meningitis, which needs immediate transport and treatment. If the parents tell you about some seizure activity, you might be dealing with a febrile seizure. These usually happen to kids between 6 months and 5 years, and have been theorized to be related to how fast the fever rises rather than how high the fever gets. These kids should be transported for evaluation because, depending on the symptoms, they might have what we call a complex febrile seizure, which would require blood work and further testing. Kids with a fever and signs of respiratory distress, like crackles on one side or a low O2, might be dealing with a pneumonia. If it's bad enough to require oxygen, these kids will probably need a round of IV antibiotics and admission to make sure that they don't get worse before they get better. While a decreased appetite is not associated with any specific disease process, sick kids, like sick adults, won't want to eat or drink as much as they should be. With their immune systems kicking in to fight infection, these kids' metabolisms will also be working harder, meaning they'll need extra hydration to keep up. If a kid has delayed cap refill or dry mucous membranes, they're already behind the 8 ball and should be getting IV fluids. Lastly, if you're running on a kid with any history of immunocompromise, like cancer, and has a fever, they 1000% need to be transported. These kids are already sick at baseline, and if their immune systems, which are already suppressed because of underlying disease or treatment, are flaring up, they have something brewing that needs to be evaluated. With all the viruses going around during flu season, it is inevitable that there are also more cases of croup. Usually caused by the parainfluenza virus, croup can be caused by any other virus by triggering swelling around the larynx and trachea. This part of the upper airway is already narrower in kids before the age of 6, so any additional inflammation, a natural response to infection, will narrow the airway even further. This results in the classic barking cough that you can identify before you even see the kid. More severe cases can lead to stridor, which is the harsh, high-pitched sound you can hear when a kid inhales. When it comes to these kids with stridor, you should always be keeping epiglottitis in the back of your mind. In contrast to croup, these kids have swelling above the vocal cords. They may start out with stridor, but these kids will decompensate pretty quickly. Classically, they look pretty sick, with difficulty swallowing and a muffled voice. Because of the epiglottic swelling, they'll also be drooling. They'll instinctively want to sit in a tripod position with their chin sticking out to maximize whatever airflow they can. These cases are some of the very few times where we want you to be doing the least. Do not inspect the airway, don't attempt IV access. Essentially, don't do anything that will agitate the patient, since we do not want to worsen the airway swelling or increase the kid's work of breathing. As we're coming up on the spring season, we'll be leaving croup behind and seeing more kids with shortness of breath. Other than stridor, wheezing is the most common abnormal lung finding we'll come across in EMS. Common things being common, these kids will most of the time be having an asthma exacerbation, but not all wheezing is asthma. That is to say, albuterol isn't always the answer. Aspirated foreign bodies and allergic reactions can also cause wheezing. Use your physical exam and history to differentiate among these diagnoses. The thing about kids with shortness of breath is that they compensate well, until they don't. If there's any sign of respiratory distress, put the kid on the monitor. Kids can maintain an acceptable oxygen saturation until they hit that point of no return. Remember to assess the work of breathing, not just the number on the monitor. If you're concerned for an allergic reaction, it's critical that you start treatment immediately. Anaphylaxis in particular can progress rapidly. When the body mistakes an allergen as a threat, it sends the immune system into overdrive, releasing histamine that causes a combination of bronchoconstriction, vasodilation, hives, and angioedema. All allergic reactions should be treated with Benadryl. Then, fall back on your ABCs. If there's wheezing or respiratory distress, give albuterol and steroids. Anaphylaxis is a true life-threatening emergency, and so you should have a low threshold to pull the trigger on IM epi. Benadryl alone is not enough to treat. Anaphylaxis is defined by the involvement of 2 or more organ systems. Therefore, if you have a patient that has hives and is hypotensive, which involves both the derm and circulatory systems, IM epi is indicated, followed by immediate transport, since the patient will need to be observed for any delayed allergic reaction. Remember that you can give IM epi as much as every 5 minutes if symptoms don't get better. Last topic for review this month are diabetic emergencies. These range from blood glucose that's too low to too high and can present very similar to each other: nausea, vomiting, and altered mental status, with a differentiating factor being a simple fingerstick glucose. Hypoglycemia, which we define as less than 60, can happen to any type of patient, which is why it's important that you keep it in your differential. In kids with diabetes, low blood glucose can be triggered by missed meals or when a kid goes through extra physical activity without eating enough carbs. It can also be caused by too much insulin, which you might expect in a kid who's getting used to a new diagnosis of diabetes. Hypoglycemia is also a common sign of drug ingestion, particularly among the young ones who are just starting to get mobile and getting into grandma's meds. Beta blockers are classic for causing hypoglycemia with low blood pressures, and oral diabetes medications like sulfonylureas will cause refractory hypoglycemia. In the school-age and pre-adolescent patients, you can also add alcohol to the list of possible ingestions that cause hypoglycemia. Hyperglycemia becomes problematic in pediatric patients around the level of 250, putting them at risk for diabetic ketoacidosis, or DKA. In kids with diabetes, their body starts to destroy the cells that produce insulin. Without insulin, their cells are unable to take in glucose to use for energy. They're essentially drowning in sugar, but starving for energy. These kids will look really dehydrated since the concentrated glucose in their blood pulls out the water from their cells. In addition to nausea and vomiting, these kids will frequently have abdominal pain, making DKA a mimicker of appendicitis. Because their dehydration is so severe, the mainstay of treatment is fluids. The sooner fluids are started, the better the outcome. Also, it's important to keep in mind that a kid doesn't need a pre-existing diagnosis of diabetes to be in DKA. If the clinical picture fits, get a finger stick. You might be the first person to diagnose a kid with diabetes. Before we end this review, a little housekeeping. A lot of you have already been using it, but for those of you who have not heard, we have a new single number for online medical control. This new number goes to both Dr. Redfield and myself, so you don't have to remember or save 2 different phone numbers. This number also allows us to record all medical control for quality assurance and is our way of keeping a record of our medical orders because similar to your written charting, if it's not documented, it didn't happen. If you don't already have the number, please reach out to your chiefs to get it. And that's all we have for this month. This review was written and produced by me, your Associate Medical Director. Our theme music is by Infraction. If you ever have any questions about any of our reviews or want to talk about a case, don't hesitate to reach out. See you next time.